Good evening and welcome to one and all present in this session. I'm Ankita from Planet. Planet is very proud to be a part of this webinar as a digital partner. I would like to share a short video of Planet. Thank you so much, everyone, for all of your patience. Planet is India's largest live digital medical content platform. Our website is www.planet.com, where we have lots of live sessions conducted by eminent speakers across the globe. And we have made Wiki services, which is medical Wikipedia for doctors only. That also you can read in your leisure time. We will invite all the doctors to visit our website. Now, without any further delay, I would like to hand over the session to Dr. Sambhu Samajkar, the General Secretary, IPSWB and EC member, the APCI. Over to you, sir. Thank you.
Thank you, Planet, for giving us your digital platform. And on behalf of Indian Pharmacological Society, West Bengal Chapter, Association of Clinical Pharmacology, India, and also Indian College of Physicians, I welcome you all to this very important symposium on inflammation and infection. So we all know after COVID-19 pandemic, what is the importance of inflammation, specifically when we are talking about infection. From our old MBBS days, we learned how inflammation actually help us when we become infected. But actually, COVID-19 pandemic tells us when we are infected, it is sometimes inflammation more dangerous than infective agent itself. So with that, we really privileged to have with us Professor Jyotirmoy Pal, the Dean of Indian College of Physicians with us, and also Professor Santanu Tripathi, the President of ACPI, Association of Clinical Pharmacologists of India. May I request Professor Jyotirmoy Pal, sir, the Dean, Indian College of Physicians, please tell us about Indian College of Physicians' different activities like this masterclass, Clinical Pharmacology and Therapeutics, and let us please start the session, sir, with your valuable blessings.
Thank you, Dr. Shambhu, Dr. Tripathi, and all the respected dignitaries and audience. It is really, I appreciate the approach of the organization to update on the most upcoming issue, that the inflammation and how targeting the inflammation we can be cure of a disease. Basically, now the recent concept is whenever some organism attack to, basically it is the inflammation that causes harm to the organ. It is not the direct organism. So addressing the inflammation is the key issue in addressing the issue that we have learned much better way during the COVID period. That is called cytokine surge. So now it is evident that every disease, if we can address the inflammation, we can get a better result. So I hope this type of symposium is very helpful for the practicing doctors, for the students and upcoming physicians. Thank you. I wish all success of the symposium. Thank you.
Thank you, Professor Pal, for your blessings. And now may I request Professor Santanu Kumar Tripathi, the President of Association of Clinical Pharmacology Society of India. Sir, please give your welcome address.
Good evening, everybody. And
sir, your video is off, sir.
There is some issue with my system, I think.
Okay.
The video is not working.
Okay, so you are audible, sir.
Yeah. So I'm here. I'm Dr. Santanu Tripathi on behalf of Association of Clinical Pharmacologists of India. I welcome everybody this evening. We are going to have this masterclass on clinical pharmacology and therapeutics on a subject which is very thought-provoking. Which has captured attention and interest in the last, say, particularly after that COVID pandemic, where we have seen a rather so intimate link between this acute infection of COVID and inflammation. And in most cases, the fatality was more or less directly attributed to the inflammation. Inflammation, as we know, is a response to any injury. But here we can consider infection where the invading microorganisms, be it bacteria or virus or whatever other microorganisms, which can possibly, we can take it as causing local injury. And it is the innate immunity which is trying to drive that out, trying to address the situation. But then its severity, or it is rather, you can say that it is also misdirected against the host and causing a lot of distress to the person who is infected. So more and more we are understanding how important this link is. And in this evening, we are going to actually discuss some of the generic issues relating to that, and as well as also a more focused area, that is use of corticosteroids in infection. Corticosteroids, we know, is otherwise have a very prominent anti-inflammatory property, but at the same time, from our undergraduate days, we have been warned against use of steroids in acute infection because of the very immunosuppressive property of it. But in certain situations, how it can help, we have also seen. We have learned with our confrontation with COVID-19, how corticosteroids could also help to a certain extent. It could also actually been found to be providing a life-saving tool also in the management of acute COVID. So some of these areas we'll be discussing. We are fortunate to have amongst us a couple of the best minds in their own field. We have Dr. Ratinder Jhaj, very brilliant clinical pharmacologist of today's in India today, as well as we have one veteran tropical medicine expert in the country, Professor Bibhuti Saha. We are fortunate to have you both today amongst us. And I must congratulate Dr. Shambhu with the kind of enthusiasm he has given this effort to have today's masterclass arrangement. Really, we all are thankful to Dr. Shambhu. I must also thank Professor Pal, Jyotirmoy Pal, who has come up and joined hands with us to have this event today on behalf of the College of Physicians. So later, instead of standing between the eminent speakers and the members of the audience, let me now stop so that let us try to listen to what Dr. Ratinder Jha as well as Professor Bibhuti Saha has to share with us. Thank you very much. Over to Dr. Shambhu.
Thank you, sir. Thank you very much. Now, may I introduce our chairperson for the first session, Professor Santanu Munshi, who is a very renowned clinical pharmacologist in West Bengal. So welcome, sir. Professor Munshi is now the professor and head at the Department of Clinical Pharmacology at School of Tropical Medicine. May I request you, sir, to please introduce our speaker, Professor Ratinder Jhaj, madam, and the subject, and we will start the academic session directly, sir.
Thank you, Dr. Shambhu. It's a unique opportunity. This is an opportunity where three organizations has come forward for this master class, and aptly so, because it's so important to highlight this issue. It's not very well talked about. We came to know about it very recently with our experience with COVID-19. And I leave it to Dr. Ratinder Jhaj, who is the very eminent speaker on this topic. And we know that there is some terminology coming up like runaway inflammation, where, inflammation is a double-edged sword. It can not only protect us, usually it is supposed to protect us, but it also can, in particular circumstances, which we realized in COVID, that it can go out of hand and cause friendly fire. So better to I invite Dr. Ratinder Jhaj to speak on this topic, and concluding remarks will be made by Dr. Jyotirmoy Pal. Dr. Jhaj.
Am I audible? And are my slides visible now?
Yes,
Yes, please.
Visible.
I seem to have, yeah, I'm on the wrong slide. Sorry, just a minute. I had tried to. Yeah, am I still visible and audible and my slides still visible? Sorry
Yes,
for
yes.
usual
Just make it
technical.
full screen. Ratinder,
Yeah,
you just
okay.
make it full screen.
Yeah.
So it will cover the most of the screen. Yeah.
Is that better?
Yeah, fine.
This is much better.
Thank you.
Much better.
Thank you. Thank you. So thank you so much. First of all, yes, to our young enthusiast, Dr. Shambhu Samrat. He has been after me actually for a long time. And finally, I could not say no to him. And thank you so much, Dr. Santanu Tripathi, Dr. Santanu Munshi, for your kind words in calling me an eminent pharmacologist. So I hope all of us jump in my topic, which in fact yes to it, because even I found it. Shantanu just said it's COVID-19 which has brought this subject to the forefront, and I'm sharing this picture with you, and I'm sure all of you recognize this to be mucormycosis, which came up. So this is a review of 101 patients. There might have been more, and we all know that there were many cases of COVID mucormycosis during COVID-19, especially in India. So out of this review of 101 patients, 82 were from India, and we also know that out of these 101 patients, 77 received steroids. So more about it we'll come to later. We'll revisit this later, but I'm going on with this thought in mind. Now, so coming back to infection and inflammation, again, some of these points have already been said by Dr. Shantanu. Now, infection is not simply invasion of an organism or a body microorganism. Infection is also a combination of the organisms with the host response. So as we all know, if the host response is sufficient, we may not suffer from any disease despite being infected, or we may be just colonized by an organism. On the other hand, if our response is not sufficient enough, we might have the infection does evolve to an infectious disease. Now, this infectious disease may again evolve to we may have be cured, we may get tolerant to the organism, or we may suffer from a chronic inflammation. And much of this depends upon the response, our host response, which is partly an inflammation in response to infection. So if our response is in fact insufficient, we will suffer from the disease, and the disease may become chronic. Or, as has been already said, if the response is either misplaced or excessive, what Dr. Munshi just called a runaway inflammation, or what has been called hyperinflammation or a cytokine storm, then we suffer from the effects of this hyperinflammation. So this brings us to the problem of dealing with this inflammation during an infection. So on the one hand, anti-inflammatory drugs in an infection, they may provide symptomatic relief by providing relief of fever, by relieving the pain, and by antagonizing this hyperinflammation and relieving the effects of the hyperinflammation. But on the other hand, as we all know, anti-inflammatory drugs can delay, diagnosis of a life-threatening infection. That is because the symptoms have been suppressed, which in turn can lead to a more severe infection before diagnosis. And also this anti-inflammatory treatment can also lead to additional or secondary or opportunistic infections, and mucormycosis is a classic example of that. So a little bit more about this inflammation in infection. Now, the drivers of inflammation in an infection, be it a bacterial infection or a viral infection, are two kinds of drivers, what we are now known as PAMPs and DAMPs. So PAMPs are nothing but pathogen-associated molecular patterns. So these are substances which are present on either the bacteria or the viruses, which are recognized by certain pattern recognition receptors, like we've all heard of toll-like receptors. So these are the TLRs are one of the pattern recognition receptors which are present on various immune cells, particularly the macrophages. And we also have DAMPs. Now, DAMPs are damage-associated molecular patterns. So these are substances that are released by our endogenous cells when they are stressed by an infection and by the subsequent inflammation. So what happens once these PAMs or the DAMs interact with say the toll-like receptors? There is a release of these inflammatory cytokines. We all know about tumor necrosis factor, interleukin-1 and interleukin-6, as well as interleukin-18 being the primary pro-inflammatory cytokines. These in turn lead to the classic signs of, inflammation or infection, that is fever, pain, the vasodilation causing vascular leakage, which could result in swelling. And these is where, we often use the NSAIDs, non-steroidal anti-inflammatory drugs, to relieve these symptoms. In addition, there is release of these acute phase reactants like CRP, ferritin, which may aid in diagnosing, these infections. And as we'll see, CRP and ferritin have also been now used to differentiate between or what we can say well and good. It saves us from it kills the bacteria, prevents the bacteria
I think there is some issue in their network. I am trying to get Madam. Yeah, madam, can you hear us? Hello, madam, can you hear us?
Yes, I can. I realized I'm talking to myself. When did I lose the connection?
Yes,
So,
yes.
my connection seems to be unstable. I'm sharing again. Yeah, am I back? Is
Yes,
the
madam.
slide also
Yes,
back?
yes.
So, so what was the last slide?
That PAMPs and DAMs.
Okay, okay. So I think, yeah, so I think we more or less covered. And as I actually already also mentioned, now it has also been recognized that CRP levels seem to be higher in bacterial infections, while ferritin levels, and this is highlighted a lot in COVID-19, are high in viral infections, and they have been used even as a marker for COVID-19. Technical glitches. Now I don't know why is it not moving. Yeah. Now, as I said, so if the inflammatory response to an infection is timely, is adequate, not too much, not too less, very, very well, we are cured of the infection, along with probably with some little help from antivirals or antibiotics. But sometimes things get a little complicated, just as this slide is looking a lot complicated, but actually there is, it's nothing too complicated. This is just a repetition of what was there on my previous slide. So we have seen, PAMPs and DAMPs causing or initiating an inflammatory response in an infection. Now, and we've already visited these inflammatory cytokines like tumor necrosis factor, interleukin 1 and 6, and there is another one called HMGB1, which are, the pro-inflammatory cytokines. But if there is an overproduction of this cytokine, what we call hypercytokainemia or cytokine storm, this causes what is called a systemic inflammatory response syndrome, and goes on to or is a initial phase of what is called sepsis. So sepsis, in fact, again, nothing but an organ dysfunction due to a dysregulated response to an infection. At the same time, our body does try to contain that by what is called a compensatory anti-inflammatory response syndrome, which goes on to tries to, suppress this inflammation. And we are, I think, all aware of, what happens due to the cytokainemia. There is, organ dysfunction mainly because of the increased vascular permeability, the capillary leak syndrome causing decreased oxygen, supply reaching the tissues and causing, organ dysfunction. And also many of these cytokines lead to cell death. So basically, this is a vicious cycle. The cell death will release DAMPs, which further activate these immune cells. There is more of a cytokine. And we have this vicious cycle, which we have seen in COVID-19, which could be fatal. Now, this is where anti-inflammation or, targets come in play during an infection. Now, we already have what we can call the classic or the conventional or the non-specific anti-inflammatory drugs like NSAIDs, corticosteroids. Some other in COVID-19 include hydroxychloroquine, colchicine, but which have unfortunately not been found to be too effective in COVID-19. Then a lot of other anti-inflammatory drugs which got a lot of attention in COVID-19 are the cytokine-specific anti-inflammatory agents, which had been around for some time, which till date had been used for, for COVID-19. Some of them have been tried for septic shock, for sepsis, but during COVID-19, many of these have been tried in little bit detail. Why am I having this problem? I'm so sorry.
Again, yes.
Yeah,
Yes.
has it come back?
Yes,
Yeah,
yes, yes.
sorry, my internet, I don't know why today. Murphy's Law, I have no problem of internet in my home, but today there's
Yeah. Madam, one thing you can do, madam, you can stop your video because
video,
that
yeah.
also save some wavelength. That is. Now it's okay, madam.
Okay, I'm still there.
Yes, madam. Yes, madam.
And my slides are still visible?
Visible. Visible.
Okay, great, great. Okay, so let's try discuss them one by one, starting with non-steroidal anti-inflammatory drugs. Now, this is, I understand everybody is a pharmacologist too. I'm not going to go into detail of mechanisms of, either NSAIDs or steroids. We all know they are COX inhibitors, lead to decrease in prostaglandins. And therefore, as I said, they're mostly used for symptomatic treatment in infectious diseases for reducing the fever or probably the pain. But what is now recognized is that NSAIDs, besides decreasing prostaglandins, also inhibit neutrophil functions and may decrease cytokine production, which could lead to a less severe infection becoming worse. And also, we all know that in infections like dengue, where there is a risk of hemorrhage, so the non-steroidal anti-inflammatory drugs, because of their antiplatelet action, may lead to bleeding. Studies in mice have also shown that ibuprofen worsens soft to infections, so should be used carefully. And in fact, I was, intrigued by a lot of literature out there about the use of NSAIDs in children. Now, none of this is conclusive evidence, but there are studies to show that, especially in varicella infections like chickenpox, use of NSAIDs like ibuprofen has been shown to, cause more of subsequent skin and soft tissue infections, especially by group A streptococci. Use of NSAIDs in pneumonia in children has been seen to worsen the pneumonia and cause complications, including empyema. And also other streptococcal infections have progressed to shock and multi-organ failure by use of NSAIDs. And we are all aware of Ray's syndrome due to aspirin. So that's something a little different altogether. Again, I'm not going into that right now. We'll leave it for discussion later if need be. And so therefore, many authorities suggest that paracetamol be the preferred antibiotic in viral infections in children. And that has been, of course, partly because of Ray's syndrome and partly because of these new risks that have come to the fore. And if at all, NSAIDs like ibuprofen, naproxen have to be used in viral infections or any infection, not just viral infection, any infection in children, they should be used only to make a child comfortable as required and not to make the child, not for normothermia. We do not have to aim for normal temperatures in infections in children using NSAID. So that is something that is now recommended. On the other hand, in COVID-19 also there was, in addition to the other fears of, anti-inflammatory action, letting the, delaying diagnosis or anti-inflammatory action, promoting multiplication of the microorganisms. Another concern during COVID-19 regarding use of NSAIDs has been that NSAID, especially ibuprofen. Why ibuprofen? Because ibuprofen has been the most commonly used NSAID during COVID-19, and so it was it has been seen that ibuprofen can increase expression of ACE2, and we all know that ACE2 receptors are used as entry receptors for SARS-CoV, but subsequent studies have shown no adverse effects, no adverse outcomes of NSAIDs and COVID-19, and all guidelines, including Indian guidelines, including NIH, WHO, have said that NSAIDs can be used in COVID-19 infections without, fear of worsening the outcomes. though, even Indian guidance do mention that you use paracetamol, but they also say you can use paracetamol or NACIDs. So that was very briefly about NACIDs in infections. Now coming to corticosteroids in infections. Corticosteroids, again, I'm not going into their mechanism. Everybody knows here how the corticosteroids act as anti-inflammatory agents. They are very potent anti-inflammatory agents. In bacterial infections, corticosteroids have been mainly used to reduce symptoms and sequelae of severe infections like bacterial meningitis, where they are especially found to be useful for pneumococcal meningitis in adults and influenza in both adults and children. And they are recommended just before or just along with an antibiotic. In tuberculosis, we all know corticosteroids have a beneficial role of decreasing mortality for both meningeal as well as pericarditis, TB. And sepsis, again, now sepsis here, is the dilemma of using steroids. So too early, and that is very similar to what we have seen in COVID-19. Very early use of corticosteroids has not been shown to improve, mortality. In fact, it has been known to adversely affect mortality in septic shock. So in septic shock or sepsis, the corticosteroids, that is IV corticosteroids, are recommended only when after vasodilators have been used and you are not able to manage a patient on vasodilator therapy. There is vasopressor therapy. Only then IV corticosteroids are recommended for septic shock. For viral infections, in fact, corticosteroids don't have much of a role. Because I think the next session is on corticosteroids, so I'm going to skip this slide. I've already lost some time in the technical glitches. So in case of viral infections, I'll straight away jump to the use of corticosteroids in COVID-19. Now, COVID-19 is a classic example of, the role and the importance of targeting inflammation in sepsis. Timing is important, patient selection is important. Too early, too much for too long may not be good, but at the right time for the right patient, it may be life-saving. And this I'm summarizing by just sharing our own guidelines. So this is our, the one-page short guidance which was released by Ministry of Health, and this is the, the last guidance that we have. And this summarizes the recommendation and the role of corticosteroids in COVID-19 today. That is, there is definite evidence, and we all know this evidence first came from the recovery trial, that dexamethasone gave a definite mortality advantage in COVID-19, but only in patients who were admitted due to COVID-19 and in patients who required oxygen. And so in these kind of patients with moderate disease, so between moderate and severe disease, there's just a dose difference. So I think I won't go over that. We know both for, whether it is moderate or severe disease, a patient who is hospitalized with COVID-19 requiring supplemental oxygen does benefit from a steroid, could be methylprednisolone, could be dexamethasone, given for 5 to 10 days. And as the guidance itself says, too long a use of steroids in COVID-19 could predispose to opportunistic infection. So please avoid, that is to be avoided. There is insufficient evidence of early use of inhaled steroids, but even the guideline says if a patient is symptomatic for more than 5 days, not hospitalized, but symptomatic, and there is a risk for getting serious COVID, that is patients who were predisposed to serious COVID, patients either elderly or with comorbidities, inhaled budesonide may be used. So this is something with just, mixed evidence for steroids in COVID-19. And so this is just, for comparison, the dose, I think we can all look up the dose later. And now revisiting the mucormycosis with steroids, we all know one of the facilitators or risk factors probably for the mucormycosis during COVID-19 was the inappropriate use of steroids. We cannot say that for sure because there were other facilitators, and one of them is diabetes. We know India is the diabetes capital of the world. So probably that is why we had the highest number of mucormycosis during COVID-19. So it's, during COVID-19 itself, there was new onset hyperglycemia in some patients. This hyperglycemia could be due to the COVID-19 itself, or it was induced by steroids and other facilitators being the immunosuppression in COVID-19, the increased iron in, that is the increased ferritin production in COVID-19, or the acidosis in COVID-19. So there were other facilitators. It's not just that steroids caused mucormycosis, but as we've seen in, in literature and in that first slide, at least 76% of the patients who had mucormycosis during COVID-19 had been given steroids. And also even in other infections or in other indications when steroids have been used, especially in patients in diabetes mellitus, even short courses of corticosteroids have led to mucormycosis, or a cumulative dose of more than 600 milligram of prednisolone or 2 to 7 grams of methylprednisolone have led to mucormycosis. So while diabetes mellitus has been a very important risk factor for mucormycosis in India, in European and American countries, it's been hematological cancers and organ transplant which have been risk factors for mucormycosis in patients of steroids. So that was very actually, quite briefly about steroids and NSAIDs in infections. Now, I also want to take this opportunity of discussing some of the cytokine-specific anti-inflammatory agents which have been used especially in COVID-19 and also in other, infections. And in fact, they have generated a lot of interest in other infections. So I'll start with the JAK inhibitors. Now, this is a very crowded, diagram, and it's okay if you cannot read any of this. This is just to indicate that JAK is the final, we all know that from our pharmacodynamics, that JAK is the final common pathway for action of cytokines. It's, JAK are the cytokine receptors. So all these cytokines are listed there because all of them act through JAK associated receptors. And we know that JAK then phosphorylates and activates the STATs, and they cause gene transcription, and they further the inflammation and the immune response. So the JAK kinase or the JAK inhibitors are small molecules which can be given orally. We know there is this baricitinib and tofacitinib which have been found useful in COVID-19, and they are in fact recommended by most guidelines to be used along with dexamethasone for patients of COVID-19 who are admitted and requiring oxygen. So this is very similar to the indication for dexamethasone, and anyway, they are used along with dexamethasone or another steroid. Interestingly, these drugs, even before COVID-19, have been tested and tried in HIV infections, and they have at least baricitinib and ruxolitinib, sorry, that's a tongue twister, have been found to be useful in HIV in reducing the viral reservoir. And how they do is actually linked to another protein, that is BCL2 proteins. Now, BCL2 are actually a family of proteins, and BCL2 in particular causing, is an anti-apoptotic protein. And being an anti-apoptotic, so it inhibits apoptosis, and it allows the virus-infected cells to live for longer, which means they act as a viral reservoir. Now, another kind of BCL2 proteins are what we call the BH3, that is BCL3 homology 3 only proteins. Now, these are pro-apoptotic. So already there is a drug called venetoclax, which is a BH3 mimetic. It has been approved by FDA for leukemia. And this has also been shown to decrease viral reservoir in HIV. And as I said, JAK actually is synergistic with BH3 in reducing viral reservoir in HIV. So that is, and now this, after COVID-19, it's generating even more interest to investigate these drugs in HIV. So that was about JAK and BCL2 and BH3 mimetic drugs. Now, another group of anti-inflammatory drugs which had been around for inflammatory disorders, but were tested for COVID-19 and found to be effective are the interleukin-6 inhibitors. Now, there are two kinds of interleukin-6 inhibitors. We have interleukin-6 receptor antibodies, that is serilumab and tocilizumab, which have been found to be effective in COVID-19 and recommended again with steroids in patients of COVID-19 who are hospitalized and who require oxygen. Their role in other infections, though under investigation, still to be defined, and we don't have very good evidence of their effectivity in any other infections. The anti-interleukin-6 monoclonal antibody, that is siltuximab, that has not been found to be effective in COVID-19. It is recommended to be used in COVID-19, but only under clinical trial conditions. So that's the status of interleukin-6 now in infections. Another cytokine which is involved in inflammation and in infection, which has been tried in COVID-19 but not found to be very effective. But years ago, in fact, this Monarchs trial is from 2001. So in 2001, since 2001, actually, as I said, so before COVID-19, these anti-inflammatory drugs have been tried for sepsis and septic shock. So this trial called Monarchs, so this was a phase 3 trial of monoclonal antibody against tumor necrosis factor. It's actually a monoclonal antibody fragment, that is ipilimumab. So that was found to be effective in sepsis, in reducing mortality, and but that only in a particular subgroup, that is patients who had high interleukin-6, which itself again indicates that the patients who had a hyperinflation. So interleukin-6 here is a marker of the inflammation. So patients who had hyperinflammation, they did benefit from tumor necrosis factor monoclonal antibodies. But in COVID-19, we are yet to have a clear-cut benefit of tumor necrosis factor antagonist. Another anti-inflammatory target, interleukin-1 antagonist, anakinra, we know it has been around. It has been used in inflammatory conditions. And it has also been effective in something called a macrophage activation syndrome. So this is a syndrome where there is hyperactivation of macrophages, which cause pancytopenia by phagocytosis of RBCs and other, and WBCs. It causes DIC. It causes liver disease. So anakinra was already, found to be useful in SLE and some kinds of arthritis, which had MAS, which, in patients who had MAS. And it has now also, been shown to be effective in patients of sepsis with features like MAS, that is called MA-like syndrome or MALS. So those are, some of the drugs, anti-inflammatory drugs, which had been around, which have been tested in sepsis at COVID-19. Some have been found useful. Some we are still trying to, decide, or we can say the jury is still out. Then very briefly, I think I won't go into detail. I think I have just 2 minutes left. There are other, anti-inflammatory targets. Now, I won't say this is newer. PAF has been, investigated as an anti-inflammatory drug right from the time we were doing. In fact, it generated a lot of interest when we were doing MD, but still, it is not translated into any anti-PAF, molecule as such. There is, as we'll see in the next slide, there is a drug, rupatadine, which is both H1 antagonist and a PAF, drug. So what has been now, I won't say now, but found about PAF is that, again, it's a pro-inflammatory, receptor. And many viruses, especially influenza viruses, have been shown to increase synthesis of PAF, which may act on the PAF receptor and contribute to lung damage during influenza. Also during COVID-19, it was proposed to be one of the factors that caused lung damage or ARDS during COVID-19, and hence rupadatin is being actually studied for in COVID-19, but again the jury is still out here. Even in dengue, PAF antagonists have been found to be useful in mice in animal studies. I'm not aware of any human studies in dengue with PAF antagonists. So that is basically, PAF, an old anti-inflammatory target, which is still being, still under investigation. Similarly, PPAR gamma, which, we know PPAR gamma agonists are used in diabetes and hyperlipidemia. Okay, that is gamma are used in diabetes, alpha are used in hyperlipidemia, and they are also known to decrease cytokine production and now being investigated as anti-inflammatory drugs in especially in respiratory syncytial virus and other respiratory viral infections. And lastly, this is something, in fact, I just came across today morning. Even and there is now an anti-complementary complement 5A antibody, that is vilobelimab, which is under phase 3, and this has been found to be useful to some extent, not really decreasing mortality. So there is no difference in mortality or vasopressor-free days or renal replacement, but it did reduce the number of days in the ICU and ventilator-free days for patients with severe sepsis and septic shock. So this is more than that, actually, frankly, even I have not, studied about 5A antibody. I'm leaving that for discussion and somebody else who has more knowledge about that. So to sum it all up, inflammation in infection is a double-edged sword, and likewise anti-inflammatory agents are double-edged swords. The correct patient selection, correct timing of anti-inflammatory medication is key to better or safer patient outcomes during an infection, as has been brought home during COVID-19. But COVID-19 has generated a lot of interest in targeting inflammation and infection. So a lot of old anti-inflammatory drugs are being repurposed for use in COVID-19 or in sepsis, septic shock due to other microorganisms, as well as new targets of inflammation are being now investigated. There's a lot of interest in them, but the common concerns remain that in inhibiting inflammation could make the existing infection worse. That it could itself be detrimental. It could reactivate other infections. It could cause secondary infections, and there are other adverse effects which actually I have really not purposely not gone into because of this lack of time. Myelosuppression and even liver disorders and pancreatitis are common adverse effects. So many of these cytokine targeted therapy, anti-inflammatory therapy. And so these are my key references. I'm just listing 4 here. And thank you for your patience listening. And I'm so sorry for the technical glitches. I don't know what happened to my internet connection today. And thank you once again, Dr. Shambhu, for having me. And thank you for all the listeners who have listened patiently. Okay, and if there are any questions and if I'm able to answer them, I'm happy to do so. I hope I have been audible.
Yes, definitely. Professor Ratinder, thank you so much for taking us over. This is a very big topic of discussion. All the anti-inflammatories you have covered, and what is important for us to understand is how to tackle this inflammation, hyperinflammation, as you said, for a long period of time, and which one to use and when to use. That is the real challenge for the clinicians.
Yes. Yes, exactly.
Because we are facing now, this is long COVID syndrome, where people are experiencing thromboembolic manifestations, coagulation problems. So that is also causing a lot of deaths. Can we move on to the next session now? Dr. Sambo?
Yes, exactly.
Yes, sir, definitely.
Yeah.
Thank you, madam. Thank you once again. Thank you, sir, for giving us your time, sir. So due to some technical glitch, we are running late. So we apologize to all the other faculties and our delegates. So thank you once again, ma'am, for giving us your valuable time. So we are now
Thank
moving
you.
towards the next session. And for that, we have two chairpersons, very noted chairpersons in the country. We have Professor Shyam Sundar sir, who is a senior professor in the field of internal medicine, and also he was the formerly president of Association of Physicians of India. And we all know his pioneering work in the field of Kalajor. Welcome you, sir. Welcome in this podium.
Thank you.
Also we have Professor Debashish Hota. He is a very noted clinical pharmacologist in the country. He is currently now the head at the Department of Pharmacology at AIIMS Bhubaneswar. Sir, we are really glad to have you with us. So now I request our chairperson, sir, both of our chairpersons to introduce the topic, and our honorable speaker, Professor Bibhuti Saha, sir, who is the very renowned in the field of tropical medicine and infectious disease, and currently head at the Department of Infectious Disease at School of Tropical Medicine. So over to our chairpersons.
Thank you, Dr. Sambo. It is really a great pleasure to be associated with this program. And this is a very important topic that you have chosen. Use of corticosteroids in infectious diseases. Now, as we were listening to COVID-19 and lecture before this, in COVID-19, steroid played a very major role. It was one of the most important drugs to save the patients. Unfortunately, steroids are used and abused in infectious diseases, and we must know what to give, how much to give, when to stop. So these questions are there, and I don't know. I mean, people do not apply their mind, which leads to, deleterious effect of steroids. So corticosteroids are wonderful drugs, but one has to know its use. Thank you. Over to Sir Yu.
Sir, is there any issue regarding the sharing, sir? Yes.
Oh, I forgot to introduce Dr. Saha. He is one of the most senior infectious disease expert in the country. He has dedicated all his life to infectious diseases. He is the head of the Department of Infectious Diseases and Advanced Microbiology in the School of Tropical Medicine, which is one of the oldest institution as far as infectious diseases are concerned. And I have great pleasure in inviting Professor Bibhuti Saha to discuss use of corticosteroids in infective disorders, a case-based discussion. Thank you.
Thank you, Professor Shyam Sundar, for your kind words of introduction. It's a very great occasion for me to be speaking in a session which is being chaired by you, sir. So, sir, what we'll do, I'll be showing some patients, and I'll be doing some review of the published literature and recommendations. And of course, as sir, you have rightly mentioned, there are words of cautions has to be there. But let me be very clear that we have heard a lot about COVID-19 for the last 3 years. So what I have done, I decided to skip COVID-19 and discuss other issues which are sometimes we are not discussing at length. So let me start with my first patient, a 63-year-old diabetic ex-smoker who has a cough and fever for 7 days, increasing shortness of breath for the last 4 days, has become drowsy for the last few hours, and he has a history of past hospital admission due to pneumonia 2 years ago, for which he required non-invasive ventilation. And at admission, the patient had a temperature of 101 degrees Fahrenheit. He was clearly hypoxic, oxygen saturation of 75% room air. CBG was high, 389. Chest showed bilateral wheeze. He has had acidosis, PCOT of 70, and the base excess was 6.3 with a lactate of 3.4. He was immediately put on mechanical ventilation, and subsequently he developed hypotension. We did fluid challenge and inotropes were added. You can see the chest X-ray, the big patch on the right side, and maybe a little bit of fluid on the left side. So he was put on piperacillin tazobactam with azithromycin, and to take care of the inflammation, he was started on IV methylprednisolone. We'll discuss the reason. Fluids were continued, inotropes were given, and also he was given prophylaxis for DVT with enoxaparin, sedation, nebulization, insulin infusion, and other supportive measures. His count was very high, 32,000. And urea 76, creatinine was 2.3. COVID RT-PCR was negative. We sent the tracheal aspirate for culture, and the CRP was 134, procalcitonin is 2.45, and NT-proBNP was little high, 768. Respiratory panel was negative for the other viruses. On second day, ABG improved a little. Patient became alert. He was needing NORAD at the rate of 5 ml per hour. SpO2 was 95%. Tracheal aspirate reported a growth of reported gram-negative bacilli. We could taper the steroid sedation, and steroids were continued. Next day, he was further improving. Inotropes were taken off. Weaning was started. Total count decreased to 28,000. Urea creatinine started dropping. Procal was 1.78. Chest was clear, and methylprednisolone was reduced 40 milligram BD. Now the tracheal aspirate grew Klebsiella pneumoniae, which was carbapenem resistant. So antibiotics was changed to ceftazidime, avibactam with aztreonam. Weaning was continued. The patient became alert. On day 5, the patient was extubated. Count came down to 12,000. Afebrile, alert, ABG was better. He was converted to oral methylprednisolone 16 milligram BD. Insulin infusion was stopped, and he was maintained on bolus insulin doses. He was now, day 6, he was requiring 2 liters of oxygen per minute. SpO2 was 93. Hypokalemia correction was started. Catheter was clamped. Central line was omitted. And you can see the chest X-ray, it has cleared to much extent. Day 7, methylprednisolone was 8 milligram BD. Oxygen taking off. Afebrile, TLC 9200, CRP, creatinine all coming down, and he was shifted to the ward. On day 8, rise to vomited. Oral feeding started. Catheter omitted. Ambulation was started. And this methylprednisolone was gradually tapered off every 2 days till day 13. Insulin requirement decreased. MDI was introduced subsequently. On day 13 of admission, he was discharged with advice for pneumococcal and influenza vaccines. So we know there is a condition known as critical illness-related corticosteroid insufficiency. What is that? This is a systemic inflammation which involves a dysregulation of the hypothalamic pituitary adrenal axis, altered metabolism of the cortisol, and there is also tissue resistance to corticosteroids. Many conditions like sepsis, septic shock, acute respiratory distress syndrome, and severe community-acquired pneumonia, they all may be associated with CIRCI. So why do we use glucocorticoid in these patients? Because, as has been discussed by my previous speaker nicely, it has a potent anti-inflammatory effect, and it also has effects on the cardiovascular tone, including the enhanced vasoconstrictor response to the exogenous catecholamines, and it inhibits the cyclooxygenase 2 and inducible nitric oxide synthesis. There are a lot of evidences, some in favor, some in against. To briefly summarize, in 1970s, Kumar and others, they did use dexamethasone or methylprednisolone, and they showed reduction in mortality. But in 1980s, Bone et al. And Sprung et al., they used high-dose methylprednisolone, but that showed it did not increase survival and induces superinfections in many patients. So steroids were taken off from the ground for a long time. Till in 2002, there's a trial by Anand et al. Who used a combination of hydrocortisone and fluorocortisone, and they showed there's a low mortality rate especially those who do not respond to the co-syntrophin stimulation test, and those who responded to co-syntrophin test, they did not show any benefit. Then 2008, there's a big famous trial, corticosteroid therapy for septic shock, where they use hydrocortisone, and it showed there's no benefit in terms of survival, but shock reversal was faster. Next, in 2016, there's a hydrocortisone for prevention of septic shock, IPRESS trial on 380 patients using hydrocortisone, and it showed that it does not prevent progression from sepsis to the septic shock. Then came the adrenal trial, the adjunctive corticosteroid treatment in critically ill patients with septic shock, with a big number of patients, 3800 patients, where they use hydrocortisone, and this compared with placebo for 7 days. This was shown to be not having an associated with survival benefit, but the shock reversal is faster, duration of mechanical ventilation was shorter, fewer blood transfusions were needed, with relatively few side effects, which was mainly in the form of hyperglycemia, which is understandable. Then in 2018, again, there's activated protein C and corticosteroids for human septic shock, APRESS trial, 1241 patients, combined hydrocortisone and fluorocortisone, and 90 days, there's fewer deaths in the steroid group, shock reversal was faster, and the steroid regimen found to be safe. As understandable, hyperglycemia was the most common adverse reaction, and even at 180 days, the survival benefit remained. So there was a Cochrane meta-analysis in 2019, where it was shown that corticosteroid therapy probably reduces hospital mortality by about 9%, results in reduction in the length of stay in the ICU by about 1 day, and in hospital stay by about 1.5 days. And the side effects were, as understandable, hyperglycemia, hyponatremia, muscle weakness, but no increased risk of superinfection, and little or no difference in terms of GI bleeding, neuropsychiatric manifestations, stroke, or cardiac events. Now we enter the area of artificial intelligence. So Piraccio and others, they did a AI study, entering data from about 2500 patients from 4 septic shock clinical trials. And what they found that when your strategy is to treat all the patients with steroids or treat no one with steroid, if you take either of these strategies, outcome is worse. In contrast, if you take an individual estimation-based treatment strategy, that gives you a positive net benefit. So on the light of all this work, Surviving Sepsis guideline came in 2021, where it was said that IV corticosteroids, that is hydrocortisone 200 milligram per day in divided doses, or as a continuous infusion for adult patients in septic shock who continue to need vasopressor therapy, that is norepinephrine or epinephrine more than 0.25 microgram per kg per minute for at least 4 hours of initiation, then you need to give steroids. And of course, this was a weak recommendation with moderate quality evidence. Recently, only on March 21st, there was a publication in NEJM, New England Journal of Medicine, hydrocortisone in severe community-acquired pneumonia. So they wanted to assess whether the anti-inflammatory and the immunomodulatory effects of the glucocorticoid reduce mortality among patients with severe community-acquired pneumonia. So what they did, a phase 3 multi-center, double-blind, randomized control trial, they assigned adults who had been admitted to the ICU for severe community-acquired pneumonia. They received intravenous hydrocortisone 200 milligram daily for either 4 or 8 days, which was determined by the clinical improvement, followed by tapering for a total of 8 to 14 days, or another group received placebo. And all these patients received the standard therapy, that is antibiotics and supportive care, and the primary outcome was death at 28 days. So what did they observe? A total of 800 patients had undergone the randomization, and note that the trial was stopped after the second planned interim analysis because it was shown to give a beneficial result. Analysis of the data was from 795 patients. By day 28, please see that death occurred in 6.2% patients in the hydrocortisone group and 11.9% patients of the placebo group. So there's an absolute difference of minus 5.6% point, which was highly significant. It was also found that in patients who was not undergoing mechanical ventilation at baseline, the endotracheal intubation was performed in 18% of the hydrocortisone group, whereas in 29.5% the placebo group. So more of the patients in the placebo group, they needed endotracheal intubation. And among patients who were not receiving vasopressors as baseline, this was initiated by day 28 in 15.3% patients of the hydrocortisone group, whereas in 25% of the placebo group. And they also found that the concerns we have, the hospital healthcare associated infections or GI bleeding, was similar in the two groups. And of course, the patients in the hydrocortisone group, they received higher doses of insulin during the first week because of the hypoglycemia induced by the steroids. So the question becomes, which steroid you use? Hydrocortisone tends to be preferred as it has a short duration action, which allows the hypothalamic pituitary adrenal axis to recover between the doses. However, you can use prednisolone, dexamethasone, or methylprednisolone because we are using them more, especially in patients who have severe inflammation, including bacterial pneumonia and ARDS. All of us know the equivalence dose of steroids, but because this is relevant in this discussion, so let's take note of that, that 1.5 milligram of dexamethasone is equal to intermediate acting 8 milligram methylprednisolone, or 10 milligram of prednisolone, which is again intermediate acting, and 40 milligram of hydrocortisone, which is short acting. So we know this. Just to recapitulate, I've kept this slide. Now the question comes, when to stop steroids? If your patient is no longer needing vasopressors, is out of shock, and is maintaining adequate blood pressure for at least 12 to 24 hours, is probably the time to consider tapering or discontinuation of steroids. However, there is an exception. The patients who have an underlying endocrine disorder or indication for using corticosteroids, in those patients, one has to taper the steroids back to their usual dose, and which has to be done very carefully. Now I come to my second patient. A 38-year-old female, thin-built, was having low-grade fever for 14 days, drowsiness for 2 days, and she had one episode of seizure on the day before admission. She was admitted in some other hospital, in a rural hospital. She was treated with ceftriaxone 1 gram IVBD, and then she was referred to us. She was hemodynamically stable, temperature 100, oxygen saturation was good, GCS was 12, plantar was bilateral mute, no papilledema, no cranial involvement, but the patient had neck rigidity. So initially thought of possibility of bacterial meningitis. We gave her ceftriaxone and vancomycin, IV fluids, and other supportive measures. The reports, all of them are fairly normal, except she had a hyponatremia 115, and the MP, dengue, scrub, leptospira were negative. And you see the CT brain, you can see a lot of edema is there, and there may be some amount of meningeal exudates. CSF was shown to have high pressure, little hazy, 345 cells with 75% lymphocytes. Protein was 121, sugar was 45. Again, the blood sugar was 125. We did a CVNAT. We found MTB was Mycobacterium tuberculosis present with rifampicin sensitive. And MGIT culture was sent. Gram stain was negative. Bacterial culture was also sent. Now we started her on antitubercular drug and dexamethasone, 6 milligram TDS. Because her body weight at 46, we took a body weight dose for 0.4 milligram per kg. So it came as 6 milligram TDS, and other supportive measures was continued. Her GCS improved, and we stopped vancomycin. Sensorium gradually improved. Riles 2 catheter removed. On day 7, we tapered the DEXA to 14 milligram. Sodium was 133. We stopped ceftriaxone also, and we discharged her on day 10 with ATD and tapering dose of dexamethasone as per the Vietnam protocol. So what is this Vietnam protocol? The great work which was done by Thwaites and others at Vietnam, what they found, they treated patients of tubercular meningitis with dexamethasone, and this showed that it reduced the risk of death. Relative risk reduction was 0.69, which is highly significant. But it was also shown that it was not associated with significant reduction in proportion of severely disabled patients among the survivors in the DEXA group, and also in proportion of patients who had either died or severely disabled after 9 months. There was no difference. So it only caused reduced risk of death, but no difference in reduction in the disability or death after disability after 9 months. And interestingly, this treatment effect was consistent across the subgroups, which were defined by disease severity grade and also by the HIV status. And interestingly, there are significantly fewer serious adverse effects in the DEXA group than in the placebo, which was again significant. What was the dose of steroids used? The patients were graded as grade 2 or grade 3. Grade 2 means GCA score of either 11 to 14 or 15 with focal neurologic sign, or grade 3 with GCA score of 10 or less. They received intravenous treatment for 4 weeks with 0.4 milligram per kg first week, 0.3 milligram per kg second week, 0.2 milligram per kg third week, and 0.1 milligram per kg fourth week. It was followed by oral treatment for 4 weeks, starting at 4 milligram per day and decreasing by 1 milligram every week. So it was a total duration of 8 weeks of steroids. Recently, there has been a review, Cochrane database review, on use of corticosteroids for managing TB meningitis. And it has found that at follow-up from 3 to 18 months, steroids reduce the death by almost 1/4. This is very high quality evidence. However, it was also shown that disabling neurological deficit is not common in the survivors, and steroid may not have any effect on this outcome. And there was no difference between the groups in the incidence of adverse events, which include GI bleeding, invasive bacterial infection, hyperglycemia, and liver function. So in a nutshell, steroids reduce the mortality without any significant side effect. Then what are the other tuberculous conditions we can use steroids? One is tuberculous pericarditis. What evidence do you have? Does it give any mortality benefit? 4 randomized control trial involving approximately 660 HIV uninfected patients were done. Pooled data showed that steroid given either direct intrapericardial injection or orally may reduce all-cause mortality by approximately 20%, with a significant reduction in pericarditis-related death. And another 3 trials which evaluated the impact of steroids on mortality in HIV-1 co-infected patients. Remember, TB is very often associated with HIV. So these 3 trials looked at impact of the steroids on the mortality in HIV-1 co-infected participants. 80% of them were not on ART. This didn't show any benefit. Then what is the impact of steroids on morbidity due to TB pericarditis? A large trial, 1400 randomized placebo-controlled study was done. And this also, of course, showed that there was lower than expected overall incidence of constrictive pericarditis. Possibly high proportion of them had HIV infection where the inflammation is less, so constrictive pericarditis is less. And it was shown that steroids reduce the pericardial constriction by 44% in patients who are given prednisolone. But they gave a word of caution. The rate of AIDS-related malignancies among the participants with advanced HIV-1 who were not given combination ART was slightly but significantly increased compared to controls. So what do we understand for this? If you have an AIDS patient or with TB pericarditis, if you plan to give steroids, the patient must be on ART. So that's an important understanding for this. Briefly, steroids for influenza. You are having an influenza outbreak, and you have seen doctors have been using steroids for the influenza. So does it have any rationale? Well, there is a Cochrane database systemic review, which included 30 studies. On meta-analysis, they found corticosteroid therapy was associated with increased mortality with odds ratio of 3.9. So you can understand there's a high chance of mortality with corticosteroids. And a similar risk of increased mortality was seen in a stratified analysis of studies who reported adjusted estimates. An association between corticosteroid therapy and increased mortality was also seen on pooled analysis of the 6 studies which reported adjusted hazard ratio. And of course, there is also increased odds of hospital-acquired infection related to corticosteroid therapy when there's pooled analysis of the 7 studies. All were unadjusted estimates. Of course, the data was graded as of low certainty, but we can understand that we should not be used corticosteroids for influenza. Now, since we are talking about infections and HIV disease has a big load of infections, so we will be showing some patients with HIV infection. My first case, you can see the first diagram prior to starting ART, chest X-ray was clear. And 4 months after ART, you can see there is a patch in the lung and the sputum was positive for acid phosphorus. Second patient, X-ray was clear before, and after 11 weeks, you can see a cavity in the left lung. Third patient, prior to ART, and after 10 weeks of ART, you can see a big left-sided pleural effusion. Fourth patient, which is has been taken from CMC Vellore database, a patient, a 43-year-old PL-HIV who completed an anti-tubercular treatment for his pulmonary TB in month of May. And then he was initiated on tenofovir ibuprofen, which was the custom that time. The CD4 was 150. And after 2 months of ART, he came with a neck swelling in August. And you can see, and the AAB was found from the swelling. So we talk about the condition known as immune reconstitution inflammatory syndrome. What is that? Occurrence or manifestations of new opportunity infection within 6 weeks to 6 months after starting ART with increase in the CD4 count. It can happen with any ARTs, especially in PL-HIV who are presenting with very low CD4 count. And though usually find this in first few weeks of ART initiation, it can occur even after 6 months. And what are the common conditions? TB, herpes zoster, severe retinitis, and cryptococcal meningitis, and there are a host of others. I'm just coming to that. You can see this big list of the pathogens. I am sorry that possibly we are not able to see this, but just to go through bacteria, there may be Mycobacterium tuberculosis. There can be non-tubercular mycobacteria. Other bacteria, virus, you can have herpes viruses, CMV, varicella zoster, hepatitis B, C, polymyxovirus, then JC virus, molluscum contagiosum. Fungi, you can have Cryptococcus, Pneumocystis carinii, Histoplasma candida, and the parasites, Toxoplasma, Schistosoma leishmania. Professor Shamsundar Sir is here. Here he's a master of leishmaniasis, Sonjaga illodosis, Cryptococcus, and also the non-pathogen associated iris can be there. Graves' disease, Guillain-Barré syndrome, rheumatoid arthritis, then polymyositis, SLE, relapsing polychondritis. So a host of conditions can present as immune reconstitution inflammation. What actually happens? You can see there are two subsets. One is A and B. A new OI has been diagnosed in a patient. It is being treated for that. Now we start ART, and after some time there's a clinical deterioration. So what can be possibility? It can be either a paradoxical iris, that means worsening. The patient is on ART, the specific OI was being treated, but still there is a worsening. So it can be a paradoxical iris, but you have to differentiate it from ART or OI treatment toxicity, opportunistic infection drug resistance, poor resistance to treatment, and other OIs. On the other hand, some patient who didn't have undiagnosed opportunistic infection, ART was started, there's a clinical deterioration, and there is a new OI diagnosis, opportunistic infection diagnosis. So it can be either unmasking iris, that means the infection was hidden, and this antiretroviral therapy has increased the immunity so that under unrecognized pathogen, they flared up and produce an immune reconstitution syndrome. Or there might have been an OI which we missed at the time of diagnosis, or because the patient is having persistent immune deficiency and the ART is taking time to recover that, so there is a new OI. So you have to differentiate from all these. So what are the risk factors for iris? Host, low CD4 count at ART initiation, presence of opportunistic infection or TB prior to ART initiation. There may be certain genetic predisposition, and there may be paucity of the immune response of the OI diagnosis, as in case of cryptococcal iris. You know, cryptococcus in immunocompromised patient, they do not produce a lot of inflammation in the meninges. So we don't have meningeal signs, the CSF cell count is low. So you can only diagnose this by clinical suspicion and demonstration of the cryptococci or cryptococcal antigen in the CSF. And regarding the pathogens, there may be dissemination of the OIs, high burden of infection, or maybe high pre-ART HIV viral load. And regarding the treatment, if there is a OI has been diagnosed and in a very short duration you are starting ART, then you can have a paradoxical iris. Or if the OI antiretroviral therapy is rapidly suppressing the viral load, then you can have a this iris. You know that nowadays the dictum is diagnose and test and treat. So many times we have seen patients who have been in a hurry to treat for the HIV. They have been started on ART without very properly working up for the opportunistic infection. And these are the patients who present to us with iris. So we have to be very careful about that. Clinical features, we are talking more about the TB iris. 2 to 4% incidence, 2 to 54% incidence. Risk factors are, as we said, short duration from TB treatment initiation to ART initiation. Nowadays, we ask them to treat after diagnosis of tuberculosis, if the CD4 is very low, less than 50, then we start ART as soon as possible. But if the patient has a reasonable CD4 count more than 200, we suggest to give at least 2 weeks of gap before starting the ART. Disseminated TB at diagnosis. As I said, low CD4 count prior to ART. Usually it happens less than 3 months. Median is 14 days. You have to differentiate it from drug-resistant TB or drug toxicity or another opportunity infection, or if the patient is not adherent to therapy, that is also to be investigated. What investigation do you do? We do a cultured or molecular testing for the drug resistant, that is gene expert, or cultures. And treatment is prednisolone. Here is prednisolone 1.5 milligram per kg for 14 days, followed by 0.75 milligram per kg for 14 days, and then reduce according to response. So this is important. The dose of prednisolone for treating TB-IDs is 1.5 milligram per kg for 14 days, followed by 0.75 milligram per kg for 14 days, and then you reduce as per the patient's response. Can we prevent these TB-IDs? Well, there is an interesting publication in NEJM in 2018, prednisolone for the prevention of paradoxical TB-IDs. So what they did, they enrolled 240 HIV-infected patients who were initiated on ART recently within last 30 days, and they had a CD4 count of 100 cells of fear. That means advanced HIV disease. The patients were given prednisolone at a dose of 40 milligram daily for 14 days, then 20 milligram daily for 14 days, or placebo. 2 groups, one group given prednisolone, another group given placebo. The primary endpoint was development of tuberculosis-associated IDs within 12 weeks after initiating the ART, as adjudicated by independent committee. Median age of the patient was 36, mostly men, and 73% had microbiology confirmed tuberculosis. Median CD4 was 49, and viral RNA, HIV1 RNA load was 5.5 log copies per minute. Total of 120 patients were assigned to each group, and 18 patients were lost to follow-up or withdrew. So what was the finding? TB-associated IDs were diagnosed in 32% of the patients of the prednisolone group and 46% patients in the placebo group. So this was highly significant. Of course, this open label, when the patient developed TB-IDs, they are given glucocorticoids. This was given 13% in the patient, the prednisolone group, and 28% patient, the placebo group. That was a relative risk of 0.47. Death was similar, 5 deaths in the prednisolone group and 4 in the placebo group. Severe infections, the things we are afraid of when you are giving steroids, occurred in 11 patients in the prednisolone group and 18 patients in the placebo group. So, of course, it occurs more in the placebo group. 1 case of Kaposi sarcoma occurs in the placebo group. The study concluded that prednisolone treatment during the first 4 weeks after initiation of ART resulted in a lower incidence of TB-associated IDs than placebo, without evidence of an increased risk of severe infections or cancer. So you can treat patients with low CD4 count less than 100 who have been recently started on ART within 1 month. You can use steroids in this dose and you can reduce the chance of TB-associated IDs. Of course, you have to exclude TB before giving steroids. Stories. A 30-year-old unmarried man started on 4-drug ATD for osteomyelitis. He came from North Bengal. He was positive for HIV, CD4 was 111, started on cotrimoxazole. After 2 weeks, he was started on ART. That time, it's a long back. He was given ART with lamivudine, stavudine, and nifavirenz. And after 2 months of 4-drug ATD, he was given continued with rifampicin INH because that was the protocol that time. Of course, we know that in continuation, we are now using rifampicin INH in ethambutol, but it's a long back story. So he was given INH. After 2.5 months of treatment, the patient developed erythematous infiltrated skin lesions on right forearm and back. You can see these are the skin lesions. You can raise erythematous skin lesion. Also on lesion on the back. You can see a satellite lesion is there. Lesions are anesthetic. There are no nerve thickening. Skin smear was negative for acid-fast bacilli. Skin biopsy from the back lesion was taken. It revealed typical histological feature of BT leprosy reaction, and CD4 count went up to 185 cells. You can see the histopathology here. The patient was treated with anti-leprotic drugs and steroids, and you see the response. So he responded well. Another case we reported, tubercular leprosy and cytomegalovirus retinitis, an immune reconstitution disease in a patient with AIDS. This patient had skin lesion here. You can see the thickened nerve. And biopsy from the skin lesion showed typical granuloma. You can see the giant cells. And the eye of the patient showed presence of exudates and hemorrhage, CMV retinitis. So this patient had, after starting of ARTs, he developed lepra reaction as well as CMV retinitis. He was treated with steroids. Of course, the vision did not improve much, but the skin lesions were improved. Next patient, a 52-year-old female from Kolkata, came to us with low-grade fever, 5 months, nodular ulcerative lesion with crusting both angles of mouth and cheek for 5 months, ulcerative lesions at dorsum of the trunk for 3 months, non-porotica for 1 month. She has a history of hysterectomy for fibroid uterus 7 years ago and received treatment of 2 units of whole blood, no significant past history. Housewife, no history of high-risk sexual behavior. And she had ulcerative lesions on the face. She was a little bit hypertensive, no lymph nodes. Scattered crepitation in lungs, diminished breath sounds in the right lower zone, and mild hepatosplenomegaly were the findings. You can see the ulcers here, right side as well as the left side. You can see the ulcer. You can see the ulcer in the left cheek. And you can see the chest X, there were infiltration in the lung, and also left lung, lower zone, there was a little bit of haziness. We took a biopsy from the left cheek. It shows presence of histoplasmosis. Histoplasma capsulatum fungal bodies were seen. So we started her on itraconazole and supportive treatment with antibiotics. We did CT abdomen. It showed hepatosplenomegaly. Adrenal was not involved. We know adrenal is an area of interest in histoplasmosis, so I need to see for adrenal involvement, which is very common, but this patient didn't have that. She was positive for HIV infection and CD4 was only 5. So we started on cotrimoxazole. The left-sided lesion cleared after 7 days of itraconazole. Initially, the right-sided lesion improved, but further improvement failed. The cough subsided after 5 days of treatment. Fever came down. You see the left side has healed, but the right side ulcer is still there. See the left side is cleared, but the right side is still showing the ulcer. So because it was a mucocutaneous area, we thought of herpes simplex and we gave her acyclovir 400 mg hourly, and this lesion cleared up. So now the cheeks are cleared. You can see the cheeks are cleared, the chest is cleared. So we are happy now, and because she had advanced HIV disease, we started her on antiretroviral therapy. That time it was ribavirin, lamivudine, and efavirenz. It was started after 28 days of itraconazole. And she was discharged and asked to come for follow-up. After 14 days, she has come back. Low-grade fever for 7 days and fresh lesions at the angle of mouth to discharge. See, there is an ulceration here. You can see the discharge and the chest X-ray again worsened. So after 2 weeks of antiretroviral therapy, we are seeing this. So we gave her antibiotics, antivirals, itraconazole was continued, heart was of course continued, no response. So did a CD4 count, now it came as 70, so 6 to 70. So we thought this is immune reconstitution inflammatory syndrome, gave her steroids, prednisolone, lesions resolved after 7 days, and we started tapering steroids. See the chest X-ray has cleared, and the cheek has also cleared. So this is iris in histoplasm, very unusual presentation. So I thought I should be sharing this with you. Another interesting case, hemophagocytic syndrome in HIV. We had a lady, 30-year-old lady who presented with fever, jaundice, cough, and progressive weakness of lower limbs. And there's no bladder involvement. She was recently diagnosed to be HIV positive and started on antiretroviral therapy. CD4 was 27. She had hepatomegaly, pancytopenia, hyperbilirubinemia, hypoalbuminemia, raised liver enzymes, and hypertriglyceridemia. CSF showed raised protein, reduced sugar and neutrophils, and DNA PCR for CMV was positive in the CSF. So then also there was evidence of CMV disease on the fundoscopy. And we did a bone marrow, and we found the hemophagocytes were there. So we thought diagnosed as a case of hemophagocytic lymphohistiocytosis, and treated her with ganciclovir, dexamethasone, and antiretroviral drugs were continued. You can see the bone marrow showing the presence of these hemophagocytes. So HLH can occur in viral diseases, bacterial diseases, fungal diseases, parasitic diseases, malignancies, and also there can be macrophage activity syndrome. So the big list of viruses, bacteria, all the known viruses, bacteria, fungus, protozoa, including the leishmania, they can cause HLH. So we must have to keep in mind about that. And what are the diagnostic criteria? There can be either molecular diagnosis or clinical diagnosis, 5 out of the 8 criteria. What are they? Fever, splenomegaly, cytopenias, including 2 or 3 lineages, hemoglobin less than 9, platelet less than 1 lakh, neutrophil less than 1000, hypertriglyceridemia or hypofibrinogenemia, fasting triglyceride more than 265, low fibrinogen, and hemophagocytes in the bone marrow or spleen or lymph node with no evidence of malignancy. And there are, of course, some newer diagnostic criteria, low or absent NK cell activity, ferritin more than 500, or soluble CD5 receptor more than 2400 IU per ml. Next is a case of an executive who came to us, was keeping unwell for a few months. Blood sugar was normal, low-grade fever, non-productive cough, and he was having respiratory distress. I'll go quickly now. I plan to finish in 5 minutes. Oral candidiasis, cyanosis, ELISA for HIV positive. Chest X-ray, you can see bilateral infiltrates, upper zones are free. CT scan. So this was a case of pneumocystis carinea pneumonia. You can see this type of cyst in staining. Treatment is cotrimoxazole and steroids. And this is a dose of steroids for moderate to severe PCP. We give steroids for first 5 days, 40 milligram BD, then for next 5 days, 40 milligram OD, and this next 10 days, you give 11 days, you give 20 milligram OD. Krishna was a vendor. He had FNEC positive for AFB, lymph node AFB positive. CD478, ATD was given. He could not afford ART. He was given cotrimoxazole prophylaxis. Came back with fever, headache, convulsions. And you can see multiple rings in the brain with edema. And this was, you can see the affection. And this was toxoplasmosis. So he was given treatment with antitoxoplasma with steroids and he responded well. A patient, not my patient, 67-year-old patient, new onset headache, imbalance, difficulty remembering things, irritable mood, GTCS, blood showed leukocytosis with eosinophilia, CT brain showed hypodensities in bilateral frontotemporal regions, drowsy, neck rigidity was present, LP showed 170 cells, mainly lymphocytic, protein was 53, glucose was 110, blood glucose was 160, TB was negative. You can see the image, so it was obviously neurocysticercosis. Interestingly, of course, the IgG antibody was positive. There are no visible or palpable nodules in the skin. Fundoscopy did not show any retinal or optic nerve head. And there was no history of pork consumption. The husband was asymptomatic. Because they know that none of the cysts was live, so started on intravenous dexamethasone. He was drowsy, fluctuating sensorium, phenytoin and clobazam added. And now you can see that there's some ring enhancement of lesion, suggesting activity of the lesions. So after edema was reduced after 2 weeks. So NCC is the most common presentation with seizures and increased pressure, and serological testing with EITB is confirmatory. ELISA has a non-specific, very poor sensitivity. Of course, before starting steroids, you have to give TB, exclude TB and strongyloids, and antidiabetic drugs are also given. For viable cyst, you have to give albendazole and steroids. You can add praziquantel. You need to take care of hepatotoxicity and leukopenia. There can be encephalitis. In these cases, don't give antiparasitic drugs, only treat the edema with steroids. And if there are interventricular cysts, you can do an endoscopic surgery. This patient was given because ophthalmic was clear, so he was given antiparasitic drugs and steroids. But after 2 weeks, he came back with this. USG right orbit showed vitreous detachment and 2 doubtful rounded lesion one in anterior chamber and near optic head. So they are possibly scolex of cysticercus larvae. So they are removed under GA and albendazole was restarted with steroid cover. So you can come up with these unusual observations. Discharge home and doing well. So you can use steroids in reducing inflammation, improving outcome. Meningitis, pneumonia, that increases mortality. But remember, in our country, because we are diagnosing meningitis very late, and it has to be started very early in the course of meningitis to give benefit. So we are not using meningitis steroids in the case of bacterial meningitis, unlike the West. So this is one observation. And also you can use it Angiostrongylosis cantonensis, neurocysticercosis, of course, we have shown, and iris, of course, we are using. but it can be detrimentally Listeria monocytogenes or cryptococcal meningitis. So we have to exclude this before starting steroids in neurological conditions. And we don't have a good utility study in viral encephalitis. In fact, we have to have more work on HSV, West Nile virus, etc. Leptospirosis, I am skipping in the interest. Typhoid fever. Do you use steroids in typhoid fever? Well, routinely no, but a study compared high-dose dexamethasone, 3 mg per kg over 30 minutes, followed by 1 mg per kg for 6 hours for 8 doses, with placebo in a double-blind trial involving 38 patients with culture positive, specifically defined severe typhoid fever. 5 to 54 years of age, all received chloramphenicol. Interestingly, the case fatality rate was 10% in the DEXA group, whereas 55.6% in the placebo group. So highly significant. And there's no significant difference in the incidence of complications in the survival. So DEXA is routinely not to be given, but all patients with suspected typhoid fever who are delirious, obtunded, stuporous, comatose, or in shock should be given DEXA. Do you give in hepatitis? Well, there's a study on fulminant hepatitis, small study, 33 children, 18 received prednisolone, 1 mg per kg, and others did not. Age, sex, and others were matched. In the steroid group, 15 survived and 3 died. In non-steroid group, 4 survived, 11 died. Highly significant. So, steroid therapy in children with fulminant hepatitis A virus is associated significantly with improved outcome and survival. We have to do more studies in future. Cholestatic viral hepatitis, where many times we are in a dilemma. The patient is having progressive jaundice after 1 month, 1.5 months. The patient parents are talking to you. Small study published, case series of 4 cases, 3 hepatitis A and 1 hepatitis B. They are given 40 mg prednisolone tapered weekly. All 4 present with progressive jaundice, anorexia, nausea, vomiting, weight loss, and pruritus. Peak bilirubin was 43, and the steroids were started from 30 to 67 days. Time taken to bilirubin to become half was approximately 2 weeks, along with improvement of symptom. Small case series, only 4 cases. So they suggested to use corticosteroids in prolonged cholestatic viral hepatitis A and E who develop severe debilitating symptom, but we don't have a long study. We need a big study to support this. Are steroids safe? Our speakers have already talked on that. We know that high-dose steroids greater than 15 to 20 mg for more than 2 to 4 weeks, they put you at risk of infections, pneumococcal pneumonia, pneumocystis, zero BC, pneumonia, hepatitis B reactivation, active TB, and disseminated strongylosis infection. I have skipped mucor. As I said, I am not touching COVID. So we think of when people are getting steroids for a long time, need to think about prophylaxis for PCP with cotrimoxazole, lamivudine for hepatitis B, INH for TB, and ivermectin for strongyloids. So we have to think of also, we may think of giving pneumococcal vaccine for people who are at risk. And a word of caution from WHO about corticosteroids. This was during the period of COVID. People are using steroids in a big way. So they cautioned us about this strongyloidosis. So this is very important. Before giving steroids in tropical countries, you need to exploit strongyloidosis. So I conclude by saying that we have various guidelines. We have recommended use of steroids in many infectious diseases, including COVID-19, which purposefully I did not touch. However, there are many gray areas. We need to work more on that. And of course, we need to keep in mind that prolonged use of steroids may lead to flare-up of occult infection. So we need to keep that in mind. So a clinician needs to take balance, advantages, disadvantage, risk, and benefit before taking final call. So thank you very much for listening for this long time to me. Thank you very much, sir.
Thank you, Dr. Saha, for this masterly disposition of your talk on corticosteroid infection is very important and you very widely covered. I invite comments from Professor Hota.
Yeah. So as a pharmacologist, we always teach that steroids are double-edged swords, and that is true. So there are evidences in favor of steroids and there are evidences against the use of steroids causing worsening of the symptoms and the condition, including fatality. So definitely it is the prerogative of the clinician to choose based upon the local infection pattern and the experience I stress upon here, the experience of the clinician is very, very vital, and that must be documented. Experience keeping within himself or within that hospital premises is practically of no use to others. So it must be disseminated, and they must publish their experience in good peer-reviewed journals so that the knowledge can be disseminated, and we must know what is to be done and what is not to be done. Very few interesting cases sir has presented, which is very, very enlightening to all of us. And what I feel that steroids, as we have seen, were largely misused. Starting from dermatology to medicine, or even quacks use maximum steroids, and they land up in a case of point of no return. So that makes the situation bad for the treating physician. So when the patient comes, so very few options are left. So definitely patient education and public education with so many media and with the instructions and publication that can help educate the media and to avoid use of steroids. However, there are definitive indications of steroids which can be life-saving. So with this, I conclude, and over to Sambho.
Thank you, sir. Thank you very much, sir. So, Professor Shamsundar, sir, any final comments, sir?
No, it was a great talk, and really I learned a lot. And I think it is a very important talk for the practice of practicing physicians,
Yes.
especially infectious disease specialist. And he has very eloquently, described various diseases, pros and cons of the using steroids. So very nice talk, and I really congratulate Professor Saha for this. Thank you.
Thank you, sir. Thank you. So we are really thankful to Bibhuti Shah, sir, and Ratinder Jhaj, madam. So we have Professor Santanu Tripathi, sir, also with us, our respected president, ACPI. So may I request, sir, to have some final comment? Sir, please unmute yourself.
Yeah, I really enjoyed the talk by both the talks were great, and particularly Professor Bibhuti Shah. It was a series of very, very interesting cases. So he's a vastly experienced person, and so nicely he have actually organized this talk. Okay, it's true that there has been some kind of confusion relating to use of steroids, and as such, in general, it is said that unless you have sufficient expertise and very clearly guided by your background understanding about, so it's better to avoid steroids in general. But then there are huge number of evidences coming, very strong evidences that in selected cases, in defined situations where you can use steroids. But what we have also heard here, that one has to be really smart in deciding, as Professor Shamsundar has very rightly pointed out in the beginning, that when to use, when to start, and then how to use. And most of the cases we have seen that it's a short use in the progression of the disease. Okay, the right time to start it, and then you have to use the right dose, then taper off if as needed. And it has shown the great benefit. Most of the cases that has been shown and the trials that he has given reference to, and in a host of different infections, viral, bacterial, and even fungal infections. So yes, it's a very, very useful tool. Only thing is, it has to be very judiciously used with continuous follow-up, and particularly in acutely infected cases. Most of the time, I'm sure that the patients were admitted in the hospital, and continuous monitoring is also important. It was a great learning. Thank you, Professor Saha. Very well organized lecture, I must say. And particularly for youngsters, it will be very useful learning for all of them. And of course, I must congratulate Professor Ratinder Jhaj. who has so nicely also discussed the broad concepts of the vital link between inflammation and infection, and also pointed out the different targets for management. And there are many things to come, in fact, in coming years about newer targets and newer drugs and the countermeasures to be developed. Pipeline, there are many pipeline drugs also. So we are really fortunate to have these two excellent speakers in two different fields, and we have learned a lot from ACPI. I congratulate the speakers and the chairpersons from both the two sessions, Professor Debashish Ota, a noted clinical pharmacologist, Professor Shyam Sundar. No, he requires no introduction really. Thank you very much, sir. We are very happy, very fortunate to have you all. And of course, Professor Santanu Munshi, who chaired the first session. And thank you very much from ACPI. It was a great evening for us. Thank you. Over to Dr. Shambu.
Thank you.
Thank you, sir. Thank you. So every good thing comes to end sometime. So we are really thankful to all our respected faculties today. And we have almost more than 150 delegates today. And this whole program has been recorded. And I think it will be very much helpful for postgraduate students, junior doctors, and other senior doctors too. And with all your permissions, our respected faculties, we can circulate this recorded video too in later part. I think, sir, you have no objection.
Yeah.
I know, sir, you
No,
are
it's
always
fine.
there to circulate, to spread the knowledge. So thank you once again, all the respected faculties on behalf of Indian Pharmacological Society West Bengal branch, ACPI, and our Inovocare E-Academy. I thank all the delegates who are also attending for last maybe almost 2 hours now, and all the chairpersons, respected speakers, and especially also our digital partner for today's event, Clarnet, for giving their online platform to spread this very important message on the link between inflammation and infection, and how can challenge those link. So over to the Clarnet people, and thank you.
Thank you everyone for sharing your valuable insights. We are more than grateful for having you here, and we hope to meet you again on this platform very soon for your next session. So with all your permission, we're concluding the session over here.
Thank you.
Thank you.
Okay, thank you so much everyone. Good night. Thank you.
Thank you all.
Good night.
Good night.